third paper, to be followed by a video as the final session, is by Jonathan Thompson from the University of Cincinnati, titled Limited Value of Haptics in Virtual Reality Laparoscopic Cholecystectomy Training.
I think so. Well, thank you very much for the opportunity to present here. I do have no conflicts to disclose. And virtual reality simulation is increasingly being adopted in training programs. There are a lot of advanced features that are being incorporated into the current generation of laparoscopic simulators. However, a lot of these features have not been shown scientifically to be of benefit. We chose to study the haptic feature in the simulator. Basically, it's the simulated force feedback. For this, we chose the Lap Mentor 2 for its immersive environment, the fact that you can do full procedures, the fact that it has simulated force feedback that you can turn on or off, and it has automated data gathering. So haptics is the science of applying tactile sensation and control to interaction with the environment. In laparoscopic surgery, you actually have two types of forces. You have interference forces, the forces of the abdominal wall recoil and the friction at the trocar, and useful forces. And sometimes the interference forces are greater than the useful forces, kind of calling into question whether haptics would be useful and of benefit in laparoscopic training. Also, the VR to OR study used a non-haptic simulator. So this was the study that proved that if you establish skills on a virtual reality simulator, those skills transfer to the OR. As well as two recent studies that showed no benefit of haptics on performance of novices when they were randomized into groups where they had the same task performed in haptics and the same task performed without haptics. So only one of 6 of these tasks actually showed a benefit of haptics in the combined studies. As well as in the Da Vinci surgical system, there are no haptics, and surgeons perform pretty complicated procedures with that, just with visual input. So our hypothesis was that haptics in current virtual reality simulators adds little benefit to the training and performance of novices. We chose to study this in a randomized controlled trial of novices. We were able to recruit 33 laparoscopy naive students. They were blindly randomized by alternating assignment by an independent scheduler, and they were randomized into the haptics, non-haptics, and control groups. They were given a presentation that introduced them to, all groups were given a presentation that introduced them to laparoscopic surgery, the laparoscopic cholecystectomy, and the laparoscopic simulator. So the training protocol for the 3 groups is as follows. We trained the haptics group with the haptics engaged to proficiency values that were derived from a prior study that got these values from both fellows and attending surgeons in a minimally invasive center. And they trained to the 9 basic tasks that are a part of the software program. The non-haptics group trained to the same expert proficiency values, again without the haptics feature engaged, and the control group, we wanted to give them just an experience with the simulator, so they performed each of the 9 basic tasks once. After this, all of the groups performed each of the 4 laparoscopic cholecystectomy procedural tasks one time, again to orient them to the procedure. And all groups performed 10 virtual cholecystectomies using the same anatomy on the Lap Mentor 2. We alternated haptics and non-haptics engaged in the virtual cholecystectomies for each group. There was quite a bit of attrition in our training groups, as it took a lot more time and sessions to train them to proficiency. than it did the control groups. As you can see, the haptics and non-haptics groups had an attrition down to 4, whereas the control group only had 1 dropout. So there were no statistical differences between the groups, but you can see that in the non-haptics group, there are no lefties. They have a little bit more video game experience and more interest in surgery. Again, not statistically significant, but we had small ends there. So this is the first thing that we looked at, which was the training efficiency. So these are the number of attempts in each of the haptics and non-haptics groups that it took to achieve expert proficiency levels. Again, they were the same proficiency targets, and these are the 9 basic tasks on the bottom. The mean and the standard deviation are shown. And basically, there were no statistically significant differences. The closest one was the clip and grasp task. And that was 0.09 was the p-value for that, again, in favor of the non-haptics group. So the next question we wanted to ask is, what was their performance over the 10 cholecystectomies? So we only looked at psychomotor metrics. There are other metrics that are involved, but we did not train them to achieve cognitive proficiency more than we trained them to psychomotor proficiency. So we looked at total time, efficiency of cautery, number of movements, path length, and speed. And we found that when we created a statistical model that controlled for learning and controlled for the haptics condition, that there was a statistically significant decrease in time for the non-haptics and haptics groups over the control, and so that was a p-value of 0.036 on the top. Then we found the number of movements of the left was decreased, as well as the total path length of the left instrument. And again, it was left, not right. So when we looked at these pairwise in the groups, we found that looking at control versus the haptics group, that there were only statistically significant differences in the number of movements of the left instrument and the path length of the left instrument. Almost half of the number of movements, 174 for the control versus 98 in the haptics, and the path length was much less, 353 for the control group versus 179. The interesting thing was that when we looked at the non-haptics group versus the control, they outperformed the control group in total time, and it was near statistical significance for efficiency of cautery. So then we looked at what the effect of haptics was, and so our statistical model for this, we controlled for group and learning, and we found that when you just look at haptics on versus off in the 10 cholecystectomies, that the number of movements of the right instrument and the speed of the right instrument was statistically increased. So you're less efficient, really, with your right hand. And then with the left hand, it's actually a benefit of non-haptics versus haptics. And so you're more efficient with your left hand when the haptics is turned on, and less efficient with your right hand when the haptics is turned on. We also wanted to look at the groups individually, whether the haptics condition affected them. And so we only had one statistically significant difference, and that was in efficiency of cautery. All of the other ones were not significant when you're just looking at haptics on versus haptics off within the groups of the cholecystectomy tests. And so pretty interesting that the haptics group was better with haptics, and the non-haptics group was better without haptics, just in this efficiency of cautery parameter. When we looked at the learning curve, I said that we controlled for learning because there was a significant learning effect in almost all of the parameters that we studied. But in total time, it's a pretty telling subjective learning curve. So if you look at the control on top, that the control group experiences more learning over the course of their cholecystectomies than the other groups. And it seems like the haptics group experiences more learning than the non-haptics group. And if you look at these trial by trial, the haptics group actually has a statistically significant difference going out to trial 3. The non-haptics group has a statistically significant difference going out to trial 4 compared to the control. There is some precedence for looking subjectively at learning curves. Gallagher in 2002 published the results on the MIST VR simulator where they had less experienced and control groups do 10 trials and looked at their learning curves and saw that there is more learning with the control groups versus the experienced. And if you look at ours kind of next to theirs, it appears that our control group is much like their control group with more learning. The haptics group is like the less experienced group with more learning than the experienced group, which is much like our non-haptics group. There were limitations of our study. We had a small sample size, again with disproportionate dropouts of our training groups. And the study design of alternating haptics and no haptics in our laparoscopic cholecystectomy tests could have influenced our statistical analysis. But notwithstanding, we think that our key findings are that efficiency of training is no different with haptics, and that the non-haptics group outperformed the control group in more parameters than the haptics group. So our conclusion with all this is that the value of haptics in training and procedural performance is not demonstrated in our study for current virtual reality simulators. And I'd like to take any questions.